All right, welcome back, everyone. We're diving into osteoarthritis of the hand and wrist today.
Yeah, a bread and butter topic.
Really important and so common, something you're definitely going to see in your practice.
Definitely. Yeah, and something that comes up a lot on the FRCS exams too.
Absolutely. It's
Okay.
one of those conditions that becomes increasingly prevalent as people get older.
It does. Yeah.
And for some reason, it seems like women are more affected than men.
Yeah, that's right. Probably because of hormones and how they affect ligaments.
Interesting. So when we talk about osteoarthritis in the hand and wrist, it's crucial to differentiate, for exam purposes especially, between primary and secondary osteoarthritis.
Yeah, that's a good point. It's one of the first things you should consider when you see a patient in clinic or are asked about it in your exams. Primary OA is often linked to genetics and the wear and tear of cartilage over time.
So just the natural aging process.
Exactly, just getting older. Secondary OA, on the other hand, typically develops after an injury.
Makes sense. So something like a fracture.
Yeah, exactly. A fracture, ligament tear, anything that disrupts the normal mechanics of the joint can predispose to OA.
So let's say a patient comes into the clinic with suspected hand or wrist OA. What are the red flags in their history that should immediately make you think, okay, this could be OA? What should I be focusing on in my history taking? This is important for both clinical practice and for the FRCS.
Absolutely. First and foremost, you want to get a clear picture of which joints are involved.
Right, because it's not going to be every single joint.
Yeah, usually it's a pattern. In the hand, the DIP and PIP joints are common culprits.
Those are the finger joints for those who might be tuning in and are not as familiar with the terminology. The distal and proximal interphalangeal joints.
Exactly. Then you've got the metacarpophalangeal joints, or MP joints, and the first carpometacarpal joint, which is at the base of the thumb.
The thumb CMC.
Yes. In the wrist, you can see OA in a few key areas. You might see it again in the first CMC, the intercarpal joints, the radiocarpal and ulnar carpal joints, and the distal radial ulnar joint, or DRUJ.
It's interesting how the thumb CMC can be affected in both hand and wrist OA. It's kind of like the bridge between the two.
Yeah, that's because it's involved in so many movements of both the hand and the wrist.
Makes sense. So we've talked about the joints, but what about the pain itself? Is there anything specific about OA pain that helps differentiate it from, say, inflammatory conditions? This is crucial for the FRCS.
Absolutely. OA pain typically worsens with activity, loading of the joint, and repetitive movements. It's like a wear and tear pain. As you use the joint more, it hurts more.
Okay, that makes sense. Is it different from the pain in rheumatoid arthritis? I remember learning that rheumatoid arthritis is more associated with morning stiffness.
Exactly. That's a key distinguishing feature. Patients with rheumatoid arthritis tend to have more pronounced morning stiffness that gradually improves with movement.
Interesting. So if someone tells you their hand pain is worse in the morning and gets better as they move around, that's more suggestive of rheumatoid arthritis than OA.
Yeah, it's a clue, not a definitive diagnosis, but a clue.
Of course. And patients with hand and wrist OA may also experience pain at night.
Yeah, they can. It can be bad enough to disrupt their sleep.
Wow, so the pain can really impact their quality of life.
It can. And the character of the pain can vary quite a bit, too. It might be a dull, aching, constant pain, or it could be sharp, intermittent, and even radiate.
So it's important to ask about all of that.
Absolutely. You need to get a detailed description of the pain, where it is, what it feels like, what makes it better or worse.
And for exam purposes, I guess it's crucial to consider other conditions that could be causing the pain, right? You don't want to just jump to OA without thinking about other possibilities.
Exactly. You have to consider both inflammatory conditions like rheumatoid arthritis and other types of arthritis, like psoriatic arthritis, for example.
So lots of differential diagnoses to consider. Okay, so let's say we've taken a thorough history. What are the key findings we should be looking for during the physical exam? What are the telltale signs of OA in the hand and wrist? Again, keeping in mind the FRCS, what should we be focusing on?
The first thing is to do your routine neurological checks. Assess their motor and sensory function.
Right, because sometimes nerve involvement can mimic joint pain.
Yeah, particularly with carpal tunnel syndrome, which we'll talk about later.
Okay, so after the neurological exam, we move on to the affected joints.
Right. And here, you're looking for anything that doesn't fit the typical OA picture. Things like triggering, which is more common with tendon problems, or signs of active synovitis, which would suggest an inflammatory process.
So redness, warmth, swelling of the joint.
Exactly. And any skin changes, like rashes or nodules, which could point to other conditions.
Good point. Now, what about the joints themselves? What should we be looking for specifically?
You want to examine each joint systematically. Look for swelling, any angular deformities, and assess their active and passive range of motion.
So how much they can move the joint on their own and how much we can move it for them.
Exactly. And try to reproduce their pain by loading the joint and sometimes by distracting it.
That makes sense. And are there any other findings that can support the diagnosis of OA apart from the joint exam itself?
Yeah, there are. Look for ligament laxity, which can contribute to joint instability and OA.
Especially in the thumb. Yeah.
Especially in the thumb, yeah. And look for Heberden's nodes at the DIP joints.
Those are the bony bumps at the end joints of the fingers, right?
Exactly. And Bouchard's nodes at the PIP joints.
So Heberden's at the DIPs, Bouchard's at the PLPs. Got it.
Good. Also, be on the lookout for ganglia or mucocysts, which can sometimes be associated with OA.
And those could be painful too, right?
Yeah, they can be. And for your exams, it's crucial to remember the strong association between first CMC-OA and carpal tunnel syndrome.
So if you see thumb-based OA, always think about carpal tunnel.
Exactly. They often go hand in hand.
Okay, so we've talked about the history and physical exam. Now, imaging is essential for confirming the diagnosis. What are the typical X-ray findings we should be looking for in OA, especially for the FRCS?
You want to get standard X-rays, including AP, lateral, and oblique views. These give you a good look at the bones and the joint space. Early on in OA, you might actually see some joint space widening.
That seems counterintuitive. I thought OA meant the joint space narrows.
Yeah, it does eventually, but in the early stages, there can be some widening due to changes in the cartilage.
Interesting. So it's not always joint space narrowing.
Right. But as OA progresses, the classic findings are joint space narrowing, subchondral sclerosis, which is hardening of the bone beneath the cartilage.
The bone is trying to compensate for the loss of cartilage.
Exactly. And you might see abernation, which is like a polishing of the bone from rubbing against bone. And then there are osteophytes, or bone spurs.
So the bony projections that form around the joint margins.
Precisely. And there are some special views that can be helpful in certain situations. For example, a Roberts view is great for looking at the trapezial articulations, which are important in thumb CMCOA. The Eaton stress view helps assess ligament laxity in the CMC joint. And while not specified in isolation, views like Betts or Geddes can help you evaluate the intercarpal relationships in the wrist.
So specific views for specific problems. And what about other imaging modalities? When would we use a bone scan or a CT scan in the context of OA?
Bone scans are sensitive for picking up erosive changes in the joints, which might suggest a more inflammatory type of arthritis. CT scans are good for visualizing cortical disruption, which can happen with cysts or fractures.
And MRI. When would we order an MRI for a patient with suspected OA?
We usually reserve MRI for cases where the diagnosis is unclear or if we need to evaluate the cartilage in more detail.
Okay, that makes sense. So it's not a first-line imaging study for OA.
Right. And remember, the severity of symptoms may not always correlate with the radiographic findings.
So someone might have terrible pain, but minimal X-ray changes, or vice versa.
Exactly. It's important to correlate the clinical picture with the imaging findings.
All right, so let's move on to treatment. Now, not every patient with OA needs surgery, obviously. Conservative management is always the first step. What are the mainstay non-operative treatments for hand and wrist OA that we should know for the FRCS?
The first line is always conservative.
Always start conservatively.
Exactly. For all the affected joints, you start with rest.
Okay, so rest the joint as much as possible.
Yes, but also apply heat for short periods, maybe 10 minutes twice a day, for pain relief.
So a hot pack or a warm bath?
Yeah, something like that. And then there are medications. Simple analgesics like acetaminophen or NSAIDs can be helpful.
NSAIDs are the non-steroidal anti-inflammatory drugs like ibuprofen or naproxen.
Right. They can reduce pain and inflammation, and splinting can be very beneficial, especially for the wrist.
So wearing a splint at night or during activities that aggravate the pain?
Exactly. The splint helps support the joint and reduce stress.
And what about therapy? What role does occupational or physical therapy play in the management of hand and wrist OA?
Therapy is key. It helps maintain range of motion, strengthens the muscles around the joint, and teaches patients how to modify their activities to protect the joint.
So it's not just about treating the pain, it's about improving function as well.
Exactly. You want to help patients regain as much function as possible.
Now, sometimes conservative measures aren't enough, and we have to consider injections. For the FRCS, what are the main types of injections used for hand and wrist OA, and when would we consider using them?
There are two main types: corticosteroids and viscosupplementation.
Corticosteroids are like a strong anti-inflammatory, right?
Exactly. They can provide significant pain relief, especially in early OA.
And viscosupplementation is like injecting a lubricant into the joint.
Yeah, it's like replacing the natural joint fluid. It's called Hyalin GF20 or Synvisc.
Okay, so those are the main non-operative options. Now let's talk about specific joints. We talked about wrist OA often being secondary to trauma. How does that affect our surgical decision-making, especially for the FRCS?
Yeah, that's right. With wrist OA, you always have to consider the underlying cause, especially if it's post-traumatic. It influences which procedures we might consider.
So if someone had a distal radius fracture that healed badly and is now causing wrist OA, we'd address that fracture malunion as part of the treatment.
Exactly. You want to restore normal joint alignment as much as possible.
Makes sense. Clinically, what are the typical signs and symptoms of wrist OA?
You'll see pain, swelling, crepitus, and sometimes ganglia.
Crepitus is that grinding sensation you feel when you move the joint, right?
Yeah, it's the bones rubbing against each other.
And on exam, what are the key things to look for?
You'll find localized tenderness, especially with loading of the joint.
So pressing on the joint reproduces their pain.
Exactly. And you want to assess for instability, such as a scapholunate gap, which can happen after a ligament injury.
And how do we check for DRUJ instability?
You can compress the DRUJ and see if it reproduces pain or if there's excessive translation.
So if the joint moves too much, that's a sign of instability.
Right. And then imaging is crucial, like we talked about earlier. You want to get dedicated wrist views to look for specific patterns of OA.
So things like SLAC wrist or SNXC wrist.
Yeah, those are common patterns. And you want to assess the DRUJ for malalignment and osteophytes.
And what about the radiocarpal and ulnocarpal joints?
Yeah, look for signs of collapse or arthritic changes in those joints as well.
Okay, so lots to look for on imaging. Now, let's say conservative management fails and we need to consider surgery. What are the surgical options for wrist OA? I know it depends on the specific area of involvement, but for the FRCS, what are the main procedures we should be familiar with?
Yeah, there are quite a few. If it's isolated to the pisotriquetral joint, sometimes just excising the pisiform bone can provide relief.
So just taking out that small bone can make a big difference.
Yeah, it can. If it's isolated to the radiocarpal joint, a radioscapholunate fusion can be a good option.
So fusing those bones together.
Exactly. For isolated midcarpal OA, a midcarpal fusion is often considered.
And what about the DRUJ?
If the DRUJ is the main problem, an ulnar head arthroplasty can be done to maintain forearm rotation.
So replacing the arthritic joint surfaces.
Right. Now, if the OA is more widespread, involving multiple areas of the wrist, then we have to consider more extensive procedures.
Like a total wrist fusion.
Exactly. A total wrist fusion, or TWF, is a good option for relieving pain and providing stability.
But the wrist is fused in a fixed position, right?
Yeah, it's usually fused in about 20 degrees of extension.
And what about total wrist arthroplasty?
That's another option, but it's more complex and has a higher risk of complications.
So it's reserved for specific cases.
Right. And sometimes we might combine a fusion or arthroplasty with a direct procedure or an ulnar head arthroplasty, depending on the situation.
It's a lot of options.
Yeah.
For the FRCS, which one should we really focus on?
Total wrist fusion is a good one to know well. It's a reliable procedure for pain relief and stability.
All right, good to know. Now let's move on to the hand, starting with the first CMC joint. What are the key anatomical and etiological points we need to remember for this joint, especially for the FRCS?
The first CMC joint, or thumb-based joint, is a saddle joint, which allows for a wide range of motion.
Yeah, the thumb is so important for grip and pinch.
Exactly. And it's a very common site of OA.
So we're going to see this a lot in our practice.
Definitely. The key stabilizing ligaments of the thumb CMC are the dorsiradial ligament and the deep anterior oblique ligament.
So those ligaments help keep the joint stable.
Yeah, they prevent the joint from subluxing or dislocating.
Makes sense. Now we talked about primary and secondary OA. How does that apply to the thumb CMC?
Primary OA is often associated with ligament laxity, which can be due to age, hormones, or just genetics.
So some people are just more prone to it.
Right. Secondary OA, as we discussed, usually follows trauma.
Like a fracture or a ligament tear.
Exactly. Both primary and secondary OA can lead to malalignment of the joint and wear and tear of the cartilage.
And that's what causes the pain and stiffness.
Exactly. Patients with thumb CMC OA will typically present with pain, swelling, and weakness of pinch and grip.
So they have trouble opening jars, gripping tools, things like that.
Yeah, everyday tasks can become difficult.
What should we be looking for specifically on physical exam of the thumb CMC joint?
You'll often find pain with distraction and axial loading of the joint.
So pulling on the thumb and pressing down on it.
Right, and as the OA progresses, you'll start to feel crepitus or grinding when you move the joint.
And palpation of the scaphotrapezoid joint can be painful too, right?
Yeah, that's the STT joint. It's often involved in later stages of OA.
And visually, what should we look for?
You might see some dorsal subluxation of the CMC joint where the metacarpal bone starts to shift out of place.
And the patient might compensate by hyperextending their MP joint and adducting their thumb.
Exactly, they're trying to maintain their grip strength.
Makes sense. The source material mentions Eaton radiographic stages for some CMC OA. Can you briefly explain those for our listeners who might not be familiar?
The Eaton classification is a system for staging the severity of thumb CMC OA based on X-ray findings.
So it helps us understand how advanced the OA is.
Exactly. Stage 1 is early OA with minimal joint space narrowing and subluxation. Stage 2 is moderate OA with more joint space narrowing, osteophytes starting to form, and some subluxation.
And stage 3 is more severe.
Yeah, stage 3 is severe OA with significant joint space narrowing, large osteophytes, and subchondral sclerosis.
So the joint is really starting to break down.
Right, and then there's stage 4 where the OA has spread to involve the STT joint.
So it's not just the CMC joint anymore.
Exactly. And then stage V is pantrapezial arthritis, meaning the entire trapezium is involved.
Okay, so 5 stages, from mild to severe. And knowing the stage helps guide our treatment, right?
Absolutely. It helps us decide whether conservative management is appropriate or if surgery is needed.
So when do we decide to operate on a patient with thumb CMCOA? What are the indications for surgery?
The main indication is pain and functional limitations that don't respond to conservative treatment.
So if they've tried all the non-operative options and they're still having trouble using their hand, then we consider surgery.
Exactly. And the goal of surgery is to alleviate their pain and create a stable, functional thumb.
So they can get back to their normal activities.
Right.
There are several surgical options for thumb CMCOA. What are the main techniques that a resident preparing for their FRCS should be familiar with?
The main options include trapezial resection, which involves removing part or all of the trapezium bone.
So taking out the bone that's causing the problem.
Exactly. And sometimes we'll use temporary fixation with a K-wire to hold the joint in place while it heals.
Okay. And what about ligament reconstruction?
Volar beak ligament reconstruction is a technique we use for early-stage OA with hypermobility. It helps tighten the ligaments and stabilize the joint.
So it's like a reinforcement procedure.
Right. And then there are osteotomy procedures.
Osteotomy means cutting and reshaping bone, right?
Exactly. An extension osteotomy of the metacarpal can be done in cases of minimal OA to shift the load away from the arthritic area.
Interesting. So it's a way of redistributing the forces across the joint.
Precisely. And then there's soft tissue interposition arthroplasty.
What is that?
It involves using a piece of tendon or other soft tissue to create a cushion between the bones after the trapezium is removed.
So it acts like a spacer.
Exactly. It's often combined with ligament reconstruction, and it's called LRTI.
LRTI, okay. And how about fusion?
Fusion or arthrodesis is another option, but it has some drawbacks.
Like what?
Well, it eliminates movement at the joint, which can be limiting for some patients.
Makes sense. And what about arthroplasty?
Arthroplasty means joint replacement. There are several types of arthroplasty for the thumb CMC joint, including hemiarthroplasty, where only one side of the joint is replaced, and total joint arthroplasty, where both sides are replaced.
So there are lots of surgical options for thumb CMCOA.
There are. The choice depends on the severity of the OA, the patient's needs and preferences, and the surgeon's experience.
Are there any key tips or takeaways regarding thumb CMC surgery that residents should know for their FRCS?
Yeah, I think the main thing is to understand the principles behind each technique and their indications. For example, arthrodesis is not always the best option, even though it provides stability. It depends on the patient's needs and activity level.
So we have to individualize the treatment.
Exactly. And with arthroplasty, it's important to be aware of the potential for instability, especially with some of the newer implant designs.
So choosing a technique you're comfortable with and that has good long-term results is key.
Exactly.
All right, let's move on to the metacarpophalangeal joints of the fingers. The source material mentions that OA in these joints is less common. What are the key points for board review?
Yeah, MP joint OA is less common than OA in other hand joints, and it's often associated with previous trauma.
So if someone had a finger fracture or dislocation, they might be more prone to developing OA in that MP joint.
Exactly. Surgically, the main options for MP joint OA are arthroplasty and fusion.
And what are the different types of arthroplasty for the MP joints?
There are pyrocarbon implants, which allow for good motion, and celastic implants, which are used in cases with poor soft tissue support.
So we choose the implant based on the individual patient.
Right. And fusion is a salvage procedure, meaning it's done when other options have failed.
So it's a last resort.
Yeah,
Yeah.
pretty much. And in some cases, we might even consider ray amputation if the joint is severely damaged and causing significant pain and disability.
Okay, so we have options, but prevention is always better than cure.
Definitely.
Now, the thumb MP joint is mentioned as the most common digit requiring surgery for OA. Why is that?
The thumb MP joint is prone to OA because of its unique anatomy and the forces it experiences during grip and pinch.
So it takes a lot of stress.
Yeah, it does. The main mechanism of OA in this joint is metacarpal base subluxation, meaning the base of the thumb metacarpal bone starts to shift out of place.
And that can lead to first web space narrowing, which is the space between the thumb and index finger.
Exactly. And the MP joint can become hyperextended and unstable.
So the thumb doesn't function properly.
Right. The goal of treatment is to restore good pinch grip strength, resistance, and stability to the joint.
And what's the main surgical option for some MPOA?
The primary option is arthrodesis, which means fusing the joint in a functional position.
And what position do we typically fuse it in?
Usually in slight flexion, about 10 to 15 degrees and about 10 degrees of pronation.
So the thumb is positioned for optimal grip.
Exactly. And there are various fixation methods we can use, depending on the situation.
Okay, moving on to the proximal interphalangeal joints, or PIP joints. It seems like post-traumatic OA is a major factor here. What are the surgical considerations for PIP joint OA?
Yeah, PIP joint OA is often post-traumatic, meaning it develops after an injury like a dislocation, a central slip injury, or an untreated mallet finger.
Those are all common hand injuries.
Yeah, they are. And untreated, they can lead to significant OA down the road.
And PIP joint OA can be really debilitating, right?
It can be. It causes pain, stiffness, and difficulty with grip and pinch.
So what are our surgical options?
The two main options are arthrodesis and arthroplasty. Arthrodesis or fusion is a reliable procedure for PIP joint OA.
It provides good pain relief and stability, right?
Exactly. And we fuse the joint in a specific degree of flexion, depending on the finger.
So each finger has its ideal fusion angle.
Right. And there are various fixation methods we can use, from K-wires to screws and plates.
And what about arthroplasty?
Arthroplasty for the PIP joint is more complex and has a higher risk of complications.
So it's not our first choice.
Not usually. It's reserved for cases where motion is essential and the bone and soft tissues are in good condition.
And what kind of motion can we expect after a PIP joint arthroplasty?
Typically, you can expect about 40 to 75 degrees of motion.
That's not bad. And what about the different types of PIP joint implants?
There are various designs, including constrained and non-constrained implants. Constrained implants provide more stability but have a higher risk of fracture.
And non-constrained implants allow for more motion but are less stable.
Exactly. The choice of implant depends on the individual patient and the surgeon's preference.
Any important tips for PIP joint surgery that residents should know for their FRCS?
Yeah, for the exams, remember that arthroplasty in the border digits, the index and little fingers, carries a higher risk of instability.
So it's not ideal for those fingers.
Right. And fusions are generally very reliable for PIP joint OA as long as the technique is good and the patient follows postoperative instructions carefully.
Okay, last but not least, let's talk about the distal interphalangeal joints, or DIP joints. These are the most commonly affected joints in OA.
Yeah, they are. DIP joint OA is super common, especially in women.
And it can cause some pretty significant deformities, right?
It can, yeah. You see those bony bumps on the end joints of the fingers called Heberden's nodes?
Yeah, those are classic. But interestingly, people can have severe deformities without any symptoms.
That's right. Some people are just bothered by the appearance, while others have significant pain and stiffness.
So the symptoms can vary a lot.
They can. And DIP joint OA has a strong hereditary component.
So if your parents have it, you're more likely to get it too.
Exactly.
The source material mentions mucocysts. What are those and how do they relate to DIP joint OA?
Mucocysts are fluid-filled sacs that develop on the back of the DIP joint. They're associated with OA and can cause pain, nail deformities, and even infection if they rupture.
So they can be problematic.
They can be. And if they need to be treated, the usual approach is surgical excision.
So we remove the cyst.
Exactly. But it's important to preserve the extensor tendon and the germinal matrix of the nail during the surgery.
The germinal matrix is what produces the nail, right?
Exactly. You don't want to damage that.
Makes sense.
Yeah.
And what about OA itself? How do we surgically treat DIP joint OA?
The most reliable procedure for DIP joint OA is arthrodesis.
Fusion again.
Yeah, it's a tried and true method for relieving pain and correcting deformity.
And in what position do we fuse the DIP joint?
Usually a neutral or slight flexion, about 10 degrees.
And we can use various fixation methods like K-wires or screws.
Exactly.
Any other surgical pearls for DIP joint OA that residents should know for the FRCS?
Yeah, a couple of things. When using K-wires for fixation, avoid crossing them, as this can increase the risk of pin tract infection.
Okay, good tip.
And use specific incisions and skin flaps to optimize healing and minimize scarring.
So careful surgical technique is essential.
Absolutely.
Well, we've covered a lot of ground today. Any final thoughts or key takeaways for residents preparing for their FRCS exams?
Yeah, I think the main thing is to remember the importance of a thorough history and physical exam when evaluating a patient with suspected hand or wrist OA.
So don't just jump to imaging.
Exactly. You need the clinical picture to guide your interpretation of the imaging findings.
Makes sense.
And always consider underlying conditions, especially trauma, which can significantly impact your management decisions.
So look for the root cause of the OA.
Right. And remember that conservative treatment is always the first line of defense.
Always start conservatively.
Exactly. Surgery is reserved for cases that fail to respond to non-operative measures.
And when it comes to surgery, there are a lot of options to choose from.
Yeah, there are. But the choice depends on the individual patient, the specific joint involved, and the severity of the OA.
So there's no one-size-fits-all approach.
Exactly. And for the FRCS, it's important to be familiar with the different surgical techniques, their indications, and their potential complications.
To study hard and know your stuff.
Exactly.
Great advice. Thanks for this comprehensive deep dive into hand and wrist OA. I think our listeners will find it incredibly helpful.
My pleasure. Thanks for having me.
Until next time, keep learning and keep striving for excellence.